Hello and welcome to the primary and secondary survey topic in the Clinical Skills for Emergency Medicine module. By the end of this session, you should be able to understand the components of primary and secondary survey, perform a complete primary and secondary survey, recognize life-threatening conditions in the emergency room, as well as manage life-threatening conditions in the A&E. Let's get started. Always assume all major trauma patients have an injured spine and maintain spinal immobilization until the spine is cleared. Priorities are the assessment and management of airway as well as the C-spine control, breathing, circulation, disability, and the exposure or environment. Prior to arrival, activate trauma team as per trauma team activation criteria. Pre-arrival briefing for team with synthesis, use of pre-arrival checklist to help with role and task allocation, and ensure personal protective equipment and aprons are worn by the trauma team. On arrival, obtain a handover from the ambulance staff, perform a primary survey, and obtain further information from family or caregivers where possible. The airway doctor is typically responsible for assessing the airway, the anterior neck, and the GCS. Their goal is to ensure and maintain a patent airway through which the patient can be successfully oxygenated. When assessing the airway, start with evidence of facial fractures, contaminants such as blood, vomit, or teeth in the mouth or airway, and epistaxis. Where the patient has suffered a burn, the airway doctor should look in particular for singing of the face or nasal hair, facial burns, hoarseness or change in voice, harsh cough, head or neck swelling, soot in the mouth, nose or saliva, and a complete airway assessment also requires an assessment of the anterior neck, looking in particular for signs of blunt or penetrating trauma or an impending airway life threat. This requires the airway doctor to open the C-spine collar whilst an assistant maintains manual inline stabilization of the cervical spine. The airway doctor should then examine the anterior neck to look or feel for the following 12 C's. Look for the tracheal deviation, wounds, emphysema, laryngeal tenderness or crepitus, venous distension, esophageal injury, and carotid hematoma. The assessment of breathing is the responsibility of the assessment doctor. Where a patient requires positive pressure ventilation, there will be a shared responsibility for the assessment of breathing by the airway and the assessment doctors. At the start of the assessment, ensure all patients are spontaneously breathing, have high flow oxygen applied, typically 10 to 15 liters of oxygen via a non-rebreather mask. Breathing is then assessed by looking at the work of breathing, whether there is recession, at the respiratory rate, as well as the accessory muscle use. Next would be the effectiveness of breathing, to look at the oxygen saturation, symmetry, and degree of chest expansion. Also look for signs of injury such as seatbelt marks, bruising, or wounds. Assessment of the thoracic cage requires feeling for emphysema or crepitus, clavicle or chest wall tenderness, and requesting a chest x-ray, which is an important addition to the primary survey. Finally, assessment also requires listening for breath sounds or added sounds. Next would be circulation. The assessment of the circulation is the responsibility of the assessment doctor. They should assess the circulatory state by checking the pulse rate, skin color, capillary refill time, and blood pressure. Looking for other effects of inadequate circulation, such as increased respiratory rate or decreased mental status. It is useful for the assessment doctor to call out the patient's vital signs at this stage of the assessment so the team is aware of them. The assessment doctor should continue with a focused assessment that involves looking for sites of potential bleeding, and these include the following sites: external bleeding, intrathoracic bleeding, intra-abdominal bleeding, intrapelvic bleeding, long bones fracture, retroperitoneal bleeding. The assessment doctor should, in consultation with the trauma team leader, consider the need for a pelvic X-ray. Next would be D for disability. The assessment of disability is typically the responsibility of the airway doctor, although the assessment doctor may add and complement this by assessing peripheral function. Initial assessment of the level of consciousness may be done using the AVPU assessment, which is A for alert, V for response to voice, P for response to pain, and U for unresponsiveness. Any impairment detected on the AVPU scale should prompt a formal assessment of the patient's GCS. Pupil response to light should be noted, as should movement in all four limbs. The assessment doctor should check for this as well as reflexes if prior to intubation where possible. The blood glucose level should be measured on arrival and periodically during the management of the trauma patient. E would be exposure and environment control. Remove clothing initially and look for any other obvious life-threatening injuries. Avoid hypothermia by limiting exposure of the body and by warming all ongoing fluids. Let's look at the secondary survey. The secondary survey is commenced after the primary survey has been completed. Immediate life threats are identified and managed. This includes a thorough examination of the head and face, neck, chest, abdomen, pelvis, limbs, and back. Let's begin with the head and face. Inspect the face and scalp. Look for bleeding, lacerations, bruising, depressions or irregularities in the skull, battle sign, which is the bruising behind the ear, indicative of a base of skull fracture. Look specifically at the eyes for foreign body, subconjunctival hemorrhage, hyphema, irregular iris, penetrating injury or contact lenses. At the ears for bleeding, blood behind tympanic membrane, which is suggestive of a base of skull fracture. Look at the nose for deformities, bleeding, nasal septal hematoma, or CSF leak. The mouth for lacerations to the lips, gums, tongue, or palate. The teeth for subluxed, loose, missing, or fractured teeth. And the jaw for pain, trismus, malocclusion suggestive of fracture. Palpate the bony margins of the orbit, the maxilla, the nose, and the jaw. The scalp or the skull looking for evidence of fracture. Test the eye movements, pupillary reflexes, vision, and hearing. Next would be the neck. Inspect the neck. It is necessary to open the collar to do this, whilst maintaining manual inline stabilization of the neck. Examine the anterior neck as per the primary survey, checking for tracheal deviation, wounds or bruising to the neck, subcutaneous emphysema, laryngeal tenderness, distension of the neck veins, and carotid pulsation and the presence of hematoma. Listen for a bruit. As for the chest, inspect the chest, observe the chest movements, look in particular for bruising, asymmetric or paradoxical chest wall movement, penetrating wounds that are rare in children, but in cases where there is a stabbing or other assault, look for hidden wounds, checking areas such as the axilla and the back. Palpate for clavicular and rib tenderness and auscultate the lung fields and the heart sounds. Now when it comes to the abdomen, inspect the abdomen, the perineum, and the external genitalia. Look for, in particular, for seat belt bruising or handlebar injuries, distension, and blood at the urinary meatus or introitus. Palpate for areas of tenderness, especially over the liver, spleen, kidneys, and bladder, and auscultate for bowel sounds. Next would be the pelvis. Inspect the pelvis for grazes over the iliac crest. Examine for bruising, deformities, pain, or crepitus on movement. As for the limbs, inspect all the limbs and joints. Palpate for bony and soft tissue tenderness and check joint movements, stability, and muscular power. Examine sensory and motor function for any nerve roots or peripheral nerves that may have been injured. As for the back, a log roll should be performed either in the primary survey or in the secondary survey. Inspect the entire length of the back and buttocks. Palpate then percuss the spine for tenderness. Palpate the scapular and sacroiliac joints for tenderness. Inspect the anus. Digital examination is rarely needed, and if it is indicated, it should be performed once. This is a quick knowledge tip on the summarized points for airway and cervical spine survey, followed by the breathing component, circulation component, and the disability component for the primary survey. We have come to the end of this session. Thank you for your time.